Welcome to our video on bacterial tracheitis, pertussis, and bronchiolitis. Let's get started. Here is our overview slide of the three topics we'll be discussing, beginning with bacterial tracheitis. With regards to this topic, we'll be discussing the general characteristics, clinical features, diagnosis, and management. Bacterial tracheitis is an invasive bacterial infection of the soft tissues of the trachea that usually occurs in the setting of previous airway mucosal damage due to a viral infection. It's most common in young children and is also more common in the fall and winter months. This is because antecedent viral illnesses such as influenza and RSV are more common in these months. The most common pathogens associated with bacterial tracheitis include Staph aureus, Strep pneumoniae, Strep pyogenes, and Moraxella catarrhalis. Bacterial tracheitis will usually have signs and symptoms of a preceding viral respiratory tract infection 1 to 3 days prior to the onset of bacterial tracheitis. Once the inflammation and exudative invasion of the trachea begins, the patient may show signs of airway obstruction such as stridor, cough, and respiratory distress. The patient may also have associated odynophagia or dysphagia. Bacterial tracheitis may present with similar characteristics to croup. However, when patients with bacterial tracheitis are given a trial of racemic epinephrine, they will have little to no improvement. Imaging and lab findings are also nonspecific. For example, a chest X-ray in a patient with bacterial tracheitis may appear similar to that of a patient with croup with a steeple sign secondary to subglottic tracheal narrowing. Additionally, there may be visible irregularity of the tracheal wall on X-ray due to the exudates present, which is a more specific imaging finding for bacterial tracheitis. Labs that should be ordered include both cultures and viral pathogen panels of respiratory specimens. The definitive diagnosis requires direct visualization of the airway via laryngoscopy or bronchoscopy. These will usually reveal adherent mucopurulent membranes of the trachea. Since bacterial tracheitis can lead to an airway obstruction, management of the airway is the first and most important step in management. One should determine the severity of the airway obstruction present and intubate if they think that the patient will require it to protect their airway. In addition, most patients will require supportive care and supplemental oxygen, as well as IV fluids. A trial of racemic epinephrine can be used, but as we mentioned before, bacterial tracheitis will typically be unresponsive, and this is due to the fact that airway obstruction is secondary to the adherent membranes rather than inflammation. This trial can be a good way to distinguish between bacterial tracheitis and croup. If there is little to no response to racemic epinephrine, it's more likely that the patient has bacterial tracheitis. Once the provider has a strong clinical suspicion of this, empiric antibiotics should be started. First-line therapies include vancomycin, plus a third-generation cephalosporin in order to cover the most common pathogens that lead to bacterial tracheitis. All right, let's try a question. A 5-year-old boy is evaluated in the hospital for difficulty breathing. He was admitted 5 days ago with stridor, a runny nose, and a mild fever. Racemic epinephrine and inhaled dexamethasone were administered for presumed croup. This patient's current vital signs are significant for a temperature of 39 degrees Celsius. His arterial oxygen saturation is 92%. The physical exam reveals persistent stridor. What is the diagnostic modality used to definitively diagnose this patient's current condition? All right, this patient has persistent stridor, a fever of 39 degrees Celsius, and a slightly low oxygen saturation of 92%. He initially had a runny nose and a mild fever, and he was administered racemic epinephrine and inhaled dexamethasone for presumed croup. However, his condition has not improved. Therefore, this patient most likely has bacterial tracheitis, which does not respond to the typical management of croup. The diagnosis can be confirmed with bronchoscopy and laryngoscopy, which reveal adherent mucopurulent membranes. Okay, let's move on to our next topic, pertussis. Again, here's the sequence of topics in which we'll be discussing pertussis, beginning with some general characteristics. Pertussis is a respiratory infection that's also known as whooping cough. It's caused by Bordetella pertussis, which is a gram-negative coccobacillus. Bordetella pertussis produces several toxins that cause local tissue damage in the respiratory tract, and a toxin that leads to systemic symptoms. Pertussis toxin can cause a lymphocytosis and hyperinsulinemia, which will result in hypoglycemia, especially in young infants. It most commonly occurs in infants that are less than 1 year of age and is more common in the summer and fall. It's highly contagious and is transmitted through respiratory droplets that are created when coughing. A classic case of pertussis infection is made up of 3 stages. The first stage is the catarrhal stage, which lasts 1 to 2 weeks. This stage is characterized by nonspecific upper respiratory symptoms such as a mild cough and nasal discharge. However, in contrast to a viral upper respiratory infection, the cough associated with pertussis will become worse. At this stage of the infection, patients are the most contagious. The paroxysmal stage is the next stage and may last for 2 to 8 weeks. This stage is characterized by the classic cough of pertussis, long paroxysms of coughing followed by a high-pitched whooping sound due to the forced inspiratory effort that occurs after a coughing fit. When a child is coughing, they may protrude their tongue, gag, or experience episodes of cyanosis. In some cases, they may even experience post-tussive vomiting. However, it's important to remember that some infants may not have the characteristic cough. The final stage of pertussis infection is the convalescent stage. This stage lasts for weeks to months after the initial infection and is characterized by a gradual reduction in symptoms. The child may continue to have coughing attacks throughout the convalescent stage, especially if they contract an upper respiratory infection. Similar to many other respiratory tract infections, pertussis is primarily a clinical diagnosis. However, there is a lab finding that may be seen on CBC in pertussis, and this is a lymphocyte-predominant leukocytosis that occurs secondary to the pertussis toxin. Confirmation of pertussis can be completed using cultures to identify the organism or PCR to identify the pertussis toxin. The management includes administering antibiotics. In children greater than 1 month of age, we can use any macrolide. However, in infants less than 1 month of age, azithromycin should be the treatment of choice. It's preferred over erythromycin due to the increased risk of pyloric stenosis, which is associated with erythromycin. Indications for hospitalization in an infant or child with pertussis include an age of less than 4 months, respiratory distress, cyanosis, and apnea. Supportive care for these children while in the hospital will include fluids and nutrition. Since pertussis is a highly contagious disease, members of the child's household and any close contacts should receive post-exposure prophylaxis. The regimen used for prophylaxis of pertussis is the same as the treatment, so macrolides. Any macrolide can be used unless the patient is less than 1 month old. If they are less than 1 month old, then again, azithromycin is the macrolide of choice. Post-exposure prophylaxis is recommended even for those who have been vaccinated against pertussis. Okay, let's move on to our last topic, bronchiolitis. Again, here's the sequence in which we'll be discussing this, beginning with general characteristics. Bronchiolitis is a lower airway viral infection that is most common in children less than 2 years old. Similar to many other respiratory tract infections, bronchiolitis is more common in the winter months. Common etiologies include respiratory syncytial virus, rhinovirus, influenza, parainfluenza virus, adenovirus, and coronaviruses. There are several risk factors that increase the risk of having severe or complicated bronchiolitis. These include prematurity, congenital cardiac disease, chronic pulmonary disease, smokers in the home, and daycare attendants. It's often preceded by a few days of upper respiratory tract symptoms, such as rhinorrhea and nasal congestion. As the illness progresses, the patient will typically experience a fever, cough, and signs of respiratory distress if it's a severe case. These signs may include retractions, head bobbing, nasal flaring, grunting, tachypnea, apnea, and cyanosis. On auscultation of the lungs, you may hear wheezing, rales, or rhonchi. Patients may also have difficulty maintaining their hydration status, so it's important to assess for signs of dehydration. These signs include decreased capillary refill, dry mucous membranes, tachycardia, and sunken fontanelles. When evaluating a child with bronchiolitis, it can be difficult to distinguish this condition from pneumonia. In general, laboratory testing is not required. A chest X-ray is also not required and should only be obtained in order to rule out other diagnoses. If a chest X-ray is ordered, it may show peribronchial thickening, hyperinflation, atelectasis, as well as a patchy scattered infiltrate. Here is a chest X-ray of an infant with bronchiolitis, and we can see flattening of the diaphragm due to hyperinflation. There are also areas of atelectasis on this chest X-ray, which can be seen as areas of opacification in the left lower lobe and the right apical areas of the lungs. We can also see an organ that's present on X-rays in neonates, the thymus. This is the sail-shaped structure that protrudes to the right side of the X-ray right here. The first step in the management of bronchiolitis is to ensure that the patient has adequate respiratory support. In children that have persistent desaturations, supplemental oxygen should be used to improve their oxygen saturation. In patients with severe illness, CPAP and/or endotracheal intubation may be required in order to provide adequate support. Most medications have little to no benefit and are not routinely recommended. In addition to monitoring the respiratory status, the patient's hydration status should be monitored and IV fluids should be given if needed due to poor oral intake. Indications for hospitalization with bronchiolitis are similar to those in other respiratory infections. They include a toxic appearance, poor feeding, and dehydration. Additionally, the patient should be hospitalized if they're showing signs of worsening respiratory distress or impending respiratory failure. In patients who are high risk for severe complications, there is an option for primary prevention. Patients who are premature, have congenital heart disease, pulmonary disease, or other risk factors can receive palivizumab. This drug is a monoclonal antibody against RSV and helps to decrease the risk of hospitalization due to severe RSV illness. All right, now that we've covered the information, let's review with a question. A 1-day-old girl is evaluated in the hospital after birth. She was born at 35 weeks of gestation via vaginal delivery. APGAR scores were 6 and 7 at 1 and 5 minutes respectively. A murmur was heard in the tricuspid area several hours after birth, which prompted echocardiographic assessment of the neonate's heart. Echocardiography showed a narrow pulmonary infundibulum, right ventricular hypertrophy, a ventricular septal defect, and an overriding aorta. Chest X-ray revealed clear lungs. What is the strongest indication for this patient to receive prophylactic palivizumab against bronchiolitis? All right, this patient was born at 35 weeks of gestation, which is a late preterm period. She had a murmur auscultated in the tricuspid area, and echocardiography showed a narrow pulmonary infundibulum, right ventricular hypertrophy, a VSD, and an overriding aorta. This description is classic for tetralogy of Fallot, which is a hemodynamically significant congenital heart disease with right-to-left shunt. This patient's chest X-ray showed clear lungs. Now, let's recall the criteria for initiating palivizumab prophylactically against bronchiolitis. Neonates born at less than 29 weeks of gestation with lung disease of prematurity or with hemodynamically significant congenital heart disease should receive prophylactic palivizumab. In this particular patient, the strongest indication is congenital heart disease, so tetralogy of Fallot. And that concludes this section.